Welcome to the Endocrine Matters podcast. This podcast episode is sponsored by Complete Medicine and Hey Healthy. Welcome to Endocrine Matters, the podcast that isn't afraid to challenge the status quo in women's health. I'm your host, Dr. Arti Thangudu, and today we're tackling a topic that perfectly exemplifies what's broken in our current healthcare system: the complete oversight of cardiovascular risk during the menopausal transition. Here's what conventional medicine often misses. While addressing hot flashes and night sweats, a woman's LDL cholesterol, triglycerides, and overall cardiovascular risk are quietly skyrocketing. The most dramatic changes happen in a narrow window, 1 year before to 2 years after the final menstrual period. Yet most women have no idea this is happening, and many physicians aren't monitoring for it, or even aware. This is exactly the kind of gap that demands we rethink how we deliver care. Today, I'm joined by my colleagues, Dr. Munira Mehta and Dr. Vidhya Illuri, both endocrinologists, and our registered dietitian and certified diabetes educator, Ana Mendez. Together, we're going to break down the science behind these lipid changes, discuss who's at highest risk and when, and give you actionable strategies from lifestyle interventions to advanced testing that can actually change outcomes. Because women deserve better than a system that waits for a heart attack to pay attention to their cardiovascular health. Let's disrupt the conventional approach and create a new standard of care. Let's dive in. Welcome, welcome, welcome. Some of my favorite people are here with me, and I'm so excited to have this conversation about women's health and women's cardiovascular health particularly, which is so important but overlooked a lot of the time. So I'd love to just kind of jump right in so we can get the conversation started. Let's start with just talking about that menopause and hormone and lipid connection. Dr. Mehta, can you explain to us just the basics? What's happening to our cholesterol in that menopausal transition?
Absolutely. So let's talk about this. It's interesting and exciting. So what we've learned over the years is total cholesterol, LDL cholesterol, and this molecule called apolipoprotein B, which is sort of like the primary structural protein of all the atherogenic lipoproteins, which include LDL, Lp(a), and we'll talk some more about those. But together, these start to rise in this perimenopause period, and that can start as early as 5 years prior to your final menstrual period, but it's really enhanced in approximately the year prior to your final menstrual period and up to 1 to 2 years after the last period that a woman experiences. And these effects are independent of age and environmental factors. And so together, as these rise, it increases your atherogenic potential and a higher risk of having cardiovascular disease.
Yeah, and just some definitions. So perimenopause is the few years leading up to that final menstrual period where women start to have hormonal changes that can lead to a plethora of symptoms. We have a whole episode on perimenopause and menopause that you can listen to learn more about that. And then the last menstrual period is like your last menstrual period, and menopause is that date, right? But we can't make a diagnosis of menopause until a year later, because that's when we really know that you have not had a period for a year. And there's this higher risk of and higher changes in cholesterol in that period 1 year before that final menstrual period and 2 years after, which is really fascinating. And I don't think that we talk about that enough. So Dr. Illuri, I'm going to bounce over to you, and I would love to hear kind of what your thoughts are on how estrogen loss affects cholesterol. We often hear about estrogen's protective effects, but what happens when we start to lose our estrogen?
So we know that estrogen itself can decrease LDL cholesterol and increase HDL cholesterol. We also know that estrogen upregulates the LDL receptors in the liver, and it improves insulin sensitivity in the liver as well. So during perimenopause and during that transition into menopause, late menopause, and postmenopause, there is a loss of estrogen. So this causes a shift towards a more atherogenic lipid profile. So now that we don't have estrogen, then LDL can go up and then HDL can go down. Then with that increased LDL, there's an increased amount of the denser LDL particles. And then there's also this increase in total cholesterol levels as well. And we also know that there's an increase in the PCSK9, and then this can also decrease the LDL receptor and cause more circulating LDL. And this is all related to the loss of estrogen that happens during menopause. We also know that when people take estrogen therapy, that can decrease LDL by 20%, and that can increase HDL by 15%. So not only do we know that the loss of estrogen can cause a more atherogenic lipid profile, but we know that when we can give estrogen back, we get a more favorable profile as well. We can even restore some of that loss that we had.
So we keep using this word atherogenic. Dr. Illuri, can you just tell us in layman's terms, what does that even mean?
Yeah, so atherogenic means that you have this lipid profile that essentially increases the risk for cardiovascular events like heart attack or stroke. So we know that when folks have higher levels of LDL, and we may have heard this as that's the bad cholesterol. And then when folks have lower levels of HDL, we kind of think of HDL as the good cholesterol. That's more atherogenic, or people are at higher risk for developing plaque disease, which can cause heart disease and stroke. So that's why we want a lipid profile that is not atherogenic. So it is really concerning during menopause and with this loss of estrogen that we do see this shift towards this atherogenic lipid profile.
Yeah, that's a good explanation. So basically, there's something called atherosclerosis. So that's when plaques develop in the arteries. And when those plaques develop, you have a higher risk for having a heart attack or stroke. So that's what that word means. I know sometimes we use this medical jargon that we're so used to using, but we really need to make it clear to our everyone out there what we're actually talking about. So that's just why I posed that question. I do also think it's important to note that while we do see improvements in cholesterol in some patients when we use estrogen therapy for menopause, there's not enough evidence to use it just for that purpose yet. Perhaps in the future, we'll be changing our tune on this. We're always learning, and I think there's a lot of interest in this space in menopause medicine right now. But right now, we don't use estrogen just to lower cholesterol or cardiovascular risk. Usually there's something else going on that indicates the use of estrogen, and then we just see some of these risks improving. But everything is based on this evidence-based risk-benefit ratio. So we haven't had enough data showing us the risks, the benefits outweigh the risks for treating with estrogen just for cardiovascular disease. There's other medications that the risk-benefit ratio is more favorable and more evidence-based as of right now, and we're recording in February of 2026. Okay, so Dr. Mehta, I would love to talk a little bit more about HDL. We talked a bit about LDL. So HDL is typically considered good cholesterol, but something sort of different happens with menopause. Can you tell us a little bit more about that?
Yes, absolutely. We think of HDL as the good cholesterol, and it has anti-atherogenic properties that we've learned about. Now, something interesting does happen. So in younger women around the age of 45 and younger, the HDL remains pretty stable around the time of their final menstrual period, whereas in older women who are 45 years of age or above, the HDL initially declines, and then there's this slight rise during the postmenopausal period. Now, it's not just about the quantitative effects on the HDL, it's also about the quality of HDL and how it undergoes some changes in this transition period. we see this happen, particularly in the menopausal transition, where the particle distribution of the HDL changes, the efflux capacity, the cholesterol efflux capacity. And all that means is that the ability of the HDL cholesterol to remove excess cholesterol particles from the peripheral tissues and the cells in your body goes down, and thereby the anti-atherogenic potential or function of the HDL cholesterol goes down. So it's not just about the number changing or diminishing or staying stable, it's the quality of the particles also seem to go through this transition in that time period.
Yeah, and I love that you pointed that out, because I think sometimes patients and doctors, all of us, get so wrapped up in lab results. Mm-hmm. But we have to take a step back, and yes, we use those lab results as part of our clinical decision making and our risk assessment and all of that, but we're here to treat people, right? And so we have to understand the whole physiology of what's going on, because there may be changes going on even if the labs are not changing. And I think your point of the quality of HDL changing is something that we need to keep in mind when we're doing a whole cardiovascular risk assessment in a patient that is very individualized based on, their family history, what's happened in their life, their lifestyle, lots of their age, where they are in their menopause status. So that's a really, really helpful and important thing you brought up. So thank you. So this is the next thing that I want to talk about is triglycerides. So triglycerides, I feel like our training has been sort of back and forth with regard to triglycerides. Triglycerides in the endocrinology world can cause pancreatitis, which can lead to diabetes. People with diabetes that have really high sugars can have high triglycerides, or vice versa. And so we think about triglycerides quite a bit in endocrinology, especially the super high triglyceride patients. They're usually our patients who come in with triglycerides over 1,000. But I think when we get into elevated triglycerides, but not over 1,000 or not over 500, that's where it becomes more murky, and there's evidence that kind of points in different directions. Dr. Illuri, will you talk to us a little bit about triglycerides in this phase, and what numbers should people be worried about? Where should we be treating? Should people be taking omega-3 fatty acids? Who should be? And I think just as a sweeping observation is that this has to be generalized and thought of as like a more complex decision than just, based on the numbers. But yeah, Dr. Illuri, I would love to hear kind of a little bit more detail on that.
Triglycerides are really important for everyone, especially women during the menopause transition. We know that triglycerides do increase during the transition and really peak in the early transition through 4 years after menopause. So it really is those first 4 years that it's really important to pay attention to this. And it is independent of age and BMI and environmental factors. So we know that these levels are changing just based on the loss of estrogen and this transition. And like you said, we know that levels above 500 are emergency, cause pancreatitis. We're really concerned about this, but we also know that levels above 200 are strongly predictive of poor cardiovascular health in women. And we know that from the Framingham Heart Study. And we also know that women who are above the age of 65 have a 2.5-fold greater increase of cardiovascular mortality if the triglycerides are in the highest quintile compared to the lowest. So really, we should aim for a fasting triglyceride level of less than 150. And if we are seeing high triglyceride levels, and if the HDL is also low, the risk increases 3.8 times fold, the cardiovascular risk. So these are really important numbers. It's not just about LDL. So if somebody has a history of cardiovascular disease, or they have risks to develop cardiovascular disease, and they're already on a statin, if the triglyceride levels are high, then we really should be, if they're above 150, really, we should really be thinking about some other intervention to bring the triglycerides down to more favorable levels. And that's when we can talk about additional medications as well as lifestyle changes. Bisepa is one of these medications that we talk about that when started on folks that have triglycerides above 150, it can reduce cardiovascular mortality.
Yeah, and we have Bisepa is like a prescription grade omega-3 fatty acid, and so I think it's interesting. We have fibrates, we have different therapies. I think triglycerides are also fascinating because they are highly variable. So like if we have patients who had a really high fat meal, like they had a hamburger before they get their labs drawn, like the night before, their triglycerides may be acutely elevated. So it's also important to understand the history of the triglyceride level. And if you're a patient listening, kind of be mindful of what you've eaten the day before, especially if it's not something you usually eat, in order to not get a false elevation. But yeah, I think triglycerides are interesting and something that we certainly need to be paying more attention to, especially in this peri and postmenopausal transition. So Dr. Mehta, tell us a little bit about risk. Who is at highest risk? Who should we be most worried about? Who should be kind of advocating for themselves when they're talking to their provider, especially when they're in this stage of life?
Yeah, this is interesting because we want to really spread this message about, because let's talk about when we're screened for lipids, right? At what age? So if you have a low cardiovascular risk, you don't have any risk factors, you don't have a history of high blood pressure, diabetes, you don't smoke, you don't have a strong family history of premature heart disease, then the screening recommendations are in men to be screened at the age of 35 and above, and then in females over age 45. But this may not apply. A lot of our patients are younger than the age of 45 and they don't have these risk factors. But when we think about these changes that happen in menopause and the loss of estrogen, some of these patients who may want to advocate for themselves and think about earlier screening should include women who go through premature menopause. It's called a condition called premature ovarian insufficiency. Our PCOS patients as well, where ovulation isn't always timely, and so the estrogen delivery and the production of estrogen isn't always consistent throughout their lifetime. They have metabolic risks regardless with the diagnosis of PCOS. Patients who go through early menopause, like under the age of 40, maybe even early 40s, is those with strong family history of hypercholesterolemia. It's important to get screened early and understand the risks associated with that early estrogen loss.
Yeah, and there are also certain ethnic groups like South Asians who tend to go through menopause earlier, or if you just know that your mom or your sisters or people in your family went through menopause earlier than the average age of 51, you may consider getting screened earlier. And again, as physicians and patients, we have to look at the whole metabolic risk. If we think a patient or you as a patient know that you have higher risk for reason X, Y, or Z, lipid panels are really easy to get. Even like the advanced cardiac markers are really easy to get and should be very inexpensive. Like I'm talking less than $10 for one test. So you need to advocate for yourself, advocate for your patients to have this testing when they need it, even if it is a little bit sooner. Okay, so Ana, I would love to chat with you about diet and lifestyle as our first line of defense. Can you tell us a little bit about what women can do with their diet and their lifestyle to help their lipid profile and their cardiovascular health and risk?
Sure. I think that this is a very important question because oftentimes women notice their cholesterol levels creep up during menopause, even if nothing in their lifestyle has changed. A really interesting study called the Pittsburgh Women's Healthy Lifestyle Project showed that women who followed a hypocaloric or slightly reduced in calorie diet, along with reduced saturated fat and regular moderate physical activity, were actually able to blunt the usual rise in LDL cholesterol during menopause. So lifestyle really does make a difference here. In practice, dietary patterns with the strongest evidence are the DASH diet, the Mediterranean diet, and plant-based whole food diets. These emphasize vegetables, fruits, more whole grains, beans, nuts, and more healthy fats like olive oil, while also limiting saturated fats and more processed foods. One of the biggest nutrients I like to focus on with my patients is dietary fiber, especially soluble fiber. These are foods like oats, beans, lentils, berries, flax seeds, chia seeds. These foods help to pull cholesterol out of the body. So even adding 1 or 2 servings of these daily can help lower your LDL over time. And then fish is another big component as well in the diet. I recommend typically at least 2 servings of fatty fish per week. These can be like salmon, sardines, trout. These have what's called EPA or DHA, which are 2 types of omega-3 fatty acids, and these help to lower triglycerides, reduce inflammation, and support overall heart health. In general, I like to stress that consistency matters more in the diet versus perfection. Small changes like having more oatmeal for breakfast or adding beans to salads or cooking with olive oil versus butter, these can lead to improvement in cholesterol levels.
I love that you brought up omega-3s. Tell us about omega-3 supplementation. Do you recommend that people use omega-3 supplements? Is fatty fish better? What do you recommend for your patients who are vegetarians?
Typically, the research suggests that omega-3s in foods are typically better. Of course, these come from mainly fatty fish, but there are supplements that can be added into the diet. So ideally, you want to consume at least fish twice a week, like I mentioned, but most Americans consume less than that. So it's important to consider supplementation if someone doesn't truly eat fish or is vegetarian or vegan. So fish oils are helpful for some women if they don't eat fish at all or if they have high triglycerides, but it's not a magic solution to addressing cholesterol levels, and they don't reliably lower LDL, so it's meant to complement a heart-healthy diet, not replace it.
I think that was like the best point, that last thing, like you can't supplement yourself into good health, right? Like you still have to have healthy habits, healthy diet, healthy overall choices. And then supplementation is just that. It's supplementation to the healthful overall choices that you're making. I think we live in this world where like it's just supplements are a billion-dollar industry, heavily marketed, pushed by people getting paid to push them. And while some of them, yes, can be helpful, most of them can't be as powerful as a healthy lifestyle, healthy diet, healthy exercise, cessation of toxic habits, all of those things. So thank you, Anna, for saying that. Dr. Mehta, I would love to chat as we get to closing about some of these advanced lipid tests. Are there advanced testing that you recommend to your patients? Do they have to have like that $1,000 lab screen from that specialized lab, or are there tests that we can offer even locally that are more easily accessible, that can be very helpful? And what do you think about calcium score?
So definitely, I think lipid panels are a great place to start, and the addition of the advanced testing panels, where usually we try to include a couple of different things like an apolipoprotein B value, which we'll talk about, and a LP little a. Those are thought of as add-on tests to further risk stratify whether you need to be on a monitoring path versus you need more aggressive, therapy with statin or other LDL lowering medications, whether lifestyle modifications are the only way to go. So it's more to risk stratify. And these can be done, as you mentioned, I think you touched on earlier, for a few dollars. It doesn't have to be a $500 advanced lipid panel. It can be a couple additional tests that we can do just from a routine blood draw. So the apolipoprotein B is thought of as the primary structural protein. We like to measure that number because it includes the LDL particle concentration. So especially in patients with insulin resistance disorders, it's nice to look at an additional parameter to help us risk stratify. Okay, what is it beyond the LDL that we can look at to tell us, is this person at higher risk or lower risk of having a cardiovascular event in their lifetime? And that number that we typically look at is about a ApoB level over 130 milligrams per deciliter is considered to be a risk-enhancing factor for atherosclerotic cardiovascular disease. And we oftentimes check this in patients who have, high triglyceride levels. They're at higher risk of having cardiovascular disease. And then the lipoprotein A it's a distinct subtype of the LDL cholesterol, and it's usually just checked once in your lifetime. It's often genetically determined. It stays stable over time. So once it's checked, it can be it gives us a lot of information. It's not something that we trend over time. So it's a one-time test. It does touch on the higher the level. If it's over 75 nanomoles per deciliter, again, there's a higher cardiovascular risk. And so some societies recommend testing for these in women who have high cholesterol levels over 220 milligrams per deciliter. Certain societies, professional societies, say, hey, we don't need to check this on everyone. So there is some difference in there's no standard recommendation, but it certainly can be considered if you want to further risk stratify some of your patients.
And I think, we have a lot of different ways that people get labs. I think the nuance is just points out the importance of having a thoughtful and credible clinician guiding your lab testing, because it can get really confusing. It's confusing enough for doctors as these guidelines change. So I feel very nervous for patients who are left alone to interpret their labs on their own without any clinical guidance for somebody who's truly looking out for them and who's able to consider their entire case thoughtfully and give them the time and explanations that they really deserve. So I think that while there are a lot of labs available, and we've discussed a lot of labs that may be helpful in assessing your risk, you shouldn't have to do that alone. And I think it's particularly important in this menopausal transition to have somebody who understands menopause, who understands lipids, who understands everything, as well as who knows you, to help you navigate this complex, challenging time for many women. So, Dr. Illuri, as we wrap up, can you just give us a quick approach to a patient in the menopausal transition who has questions about their cardiovascular risk? What are the first maybe 5 things you would do or talk about with that patient?
So obviously we would check a lipid panel to see kind of where they were. And it would be nice if we had something from previous years to compare where they are now and where they were. One thing that we do with all our patients is we calculate a 10-year risk of cardiovascular risk. So that's something that we can do to risk stratify our patients and just see where they are and what their risk is for developing cardiovascular disease, and if they would be someone who could benefit from lifestyle changes or even initiation of medication. So that's the first thing that I would do. And really for every patient that we see, we do a full dietary history, we do a full exercise and sleep history, and we see what they're doing. And most of the time, there are things that we can change or modify in just their daily life habits that could be really beneficial for reducing their risk of developing cardiovascular disease in the future. So that would be kind of where I would start. Now, if we're in the case where they're kind of at intermediate risk and we aren't quite sure if a statin could be beneficial or if it's not beneficial, that's where we could suggest some of these advanced studies like the coronary artery calcium scoring that could help us make an educated decision on whether medication would be helpful for them. Right now, statins do remain the mainstay of therapy for lowering lipid panels. We had touched on this before. It is not, though, that there are other medications that can decrease risk of coronary vascular disease in the future, such as GLP-1 agonists and some of the other things we talked about. Statins really are the gold standard of therapy for lipid lowering and improving cardiovascular risk. So that might just be something that we talk about with each one of our patients. But again, this is going to be an individualized decision based on what is going on with the patient that we have in front of us.
Thank you. That was a great overview. And just to look into how we really should be thoughtfully approaching this. And not every patient is going to be the same. And that's perfectly okay. And that's actually why we're here. So thank you so much for that. And thank you guys all for just sharing your expertise. I think it's so valuable to have multiple experts, especially also having Anna's expertise here to just give us a multifaceted approach to a patient who may be dealing with several metabolic changes at the same time. And I think the key point is that the menopausal transition is a critical window for assessing cardiovascular health. And we really need to be aware of that, keep it in mind when we're assessing patients and talk to them about it so that they understand. And women and women's healthcare providers really need to consider that more than we have been historically as we continue to see women patients and more women are coming out asking for menopausal care. So our listeners, thank you so much for being here today. If you like this episode, please share it with anyone who you think could benefit. Subscribe to our YouTube channel and follow, like, share, all of those things help us get the word out so much. So thank you for doing that. If you want to see us in clinic, you can see any of us. You can find us on sacomplete.com, and that will give you more details about us and our clinic and how you can work with us. And please follow me at Dr. Arti Thangudu on Instagram for more educational tips and tricks.